All right. Well, thank you everybody for joining us today. Excited to talk about this with you all. So today we're going to be covering IRB protocols, recruitment, and consent. So these are some of the really important parts of IRB submissions. We've talked in the past about the submissions as a whole. We've had some sessions on common issues with submissions, but this is really designed to give you a little bit of a closer look at these three specific parts of the IRB application process and the study process. So we're going to be talking about study subjects, protocols, recruitment, informed consent, consenting process, and then just a little bit about documents. All right, so first up, study subjects.
Lauren?
Yes?
We cannot see your screen.
Oh, okay. Thank you very much. I will.
Mm-hmm.
All right. Did that work?
Perfect. Thank you.
Awesome. Thank you. Okay. So talking about subjects first. So when we talk about enrolled subjects, it's really important to understand what we mean by a subject. So when we say enrolled subjects, we mean somebody who signed a consent form or whose data you've collected. In the cases where consent isn't required, like with the data chart review, it would also include somebody whose medical record you've reviewed. So when we talk about subjects, whether it's how many people you've enrolled or enrollment details, this is essentially what we mean. So it's not just somebody that you've talked to, it's somebody who's actually been enrolled in the study and is ready to go. Subject populations are related, but slightly different. So when we talk about subject populations, we're talking about the different groups of subjects that you may have in your study. So remember, if you're collecting data on someone, they're a subject. This also includes somebody you might be interviewing or administering questionnaires to. And some studies have more than one subject population. This is actually fairly common. So for example, if you're doing an educational study, you might be looking at students on the one hand, and you might be surveying the parents of these students on, say, how they found a program's implementation in their classroom. So in that case, you would have students as your subjects, and you'd also have your parents. Same, in a related sense, if you're doing a medical intervention and you want to ask medical providers what they think about this particular intervention, and you're also getting data from patients, you're also going to have two subject populations. It's important to distinguish between these two because it's possible that different subject populations are going to be doing different things. So going back to the case where you have a medical intervention, the patients are obviously going to be getting the intervention itself. They may be filling out some questionnaires, they may be providing other data to you. And then you have the providers as a different subject population. Now the providers are not going to be undergoing the medical intervention, obviously, they're going to be the ones administering it. So they may be filling out related questionnaires, but not the same ones. So it's really important when we talk about subject populations in our protocol and in our SMART forms that we clarify whether or not we have multiple subject populations, what these different populations are, and what's going to happen to each of them. So when we talk about protocols and study descriptions, we're essentially talking about the roadmap for research. So when we ask the question, what do we require for a protocol? So your protocol is your research plan described in detail. There is a variety of things that you'll need to include in there, but inclusion and exclusion criteria, and then the procedures and the timeline are really important ones. So when we talk about inclusion, exclusion criteria, essentially we're asking of these subjects, these people that we're hoping to enroll, is there anything that's gonna prevent them from participating? And what kind of subjects are we targeting? So again, for an educational intervention, you might be targeting young people from 13 to 18. And if they're younger than that, you're not interested in them. That's not necessarily who this study is about. So you would want to make that clear. Likewise, if you're doing some sort of medical study and it's not really a good fit for pregnant people, you might exclude people who are pregnant. So it's important in the protocol to describe this in detail because it's really your guide as you move forward throughout the study. You talk to all sorts of different people. It's your guide for determining whether or not this person is a good fit for your study. Likewise, procedures and timeline. So in a lot of studies, this is fairly straightforward. If you have a medical study that's essentially a blood draw, you talk about, okay, here's who we're going to recruit. These are the people we want to talk to. We're going to draw blood from them. This is how much blood we're going to draw. And maybe we do it at hospital admission and then as people are going home from the hospital. That's a fairly straightforward protocol. But there are a lot of protocols that are considerably more complex than that. So you may have different interventions. If you have something like a crossover design where people are going to be in one condition and then later they'll be in another condition, and you have people switching sort of vice versa, that can be a little bit more complex. Or if it's something where there's different stages to the intervention. Some medical studies have like washout periods ahead of time where people can have to stop taking whatever drug or can't drink grapefruit juice or what have you. So laying out your procedures and your timeline is really important, again, because this protocol document is designed to be a roadmap as you go through the research, as you work with your participants, and then as you report what you're doing. So it's important to know that some study types, like exempt studies, have a study description rather than a protocol document. This is going to be something within our SMART forms that asks questions. Again, what are your inclusion/exclusion criteria? What are the procedures to be followed? Similar to a study protocol, but rather than having a separate protocol document, these types of studies have study descriptions. And we do have some resources here. We have samples, templates, guidelines. All of this has more information on what specifically we're looking for in protocols. So is my protocol clear? So one of the things I like to advise is when you're looking at your protocol, it can be really easy to get so in depth with what you're doing because you're working on this project every single day. You've been working on it for years sometimes. It can be really easy to get so close to it that things that sound really clear to you may not be as clear to someone who is less familiar with the project. So when you read your protocol, ask whether or not somebody who is outside your department, maybe is in a similar field, ask whether or not they could read your protocol and then tell you who are you studying, what's going to happen to each participant, and at what time points procedures are going to happen. And this is just a way of sort of stepping out of your research role and looking at the protocol from the perspective of somebody who is not on the project, who may not be as familiar with the specific medical condition, the specifics of the subjects, and really making sure that when you submit your protocol to the IRB, it's easy for staff and reviewers to figure out what's going on. There are some mistakes that we see with protocols. One of the things that we see, and we often ask study teams to clarify, is what's happening at UF. So this mainly impacts things that are sponsor written, multi-site studies, studies where you have different sites, different places that are implementing protocols. So Florida and UF have specific local laws and policies. So one of the things that Florida state law regulates is pregnancy testing for minors for research only purposes. So if this is something that your study is going to be doing, it's important to specify whether or not this is going to be happening at UF. You may be involved in a study and the only thing you're going to be doing is following up with patients who are already on board. They would have had a pregnancy test elsewhere. That's fine. It doesn't, that's not an issue from the IRB perspective. What's important is that we know what's happening so that we know how to apply these regulations and whether or not these regulations are appropriate for your individual study. So the best way to do this is if it's not entirely clear whether or not everything in the protocol is going to be happening here at UF and with UF patients, give a brief summary of what's going to happen at UF with UF patients, and add that to question 3.0 of the miscellaneous SMART form. This lets the reviewers, again, take a look at it, see what's happening here at UF, and then figure out whether some of these local context laws apply to what you're doing. Related, standard of care. So in medical studies, we often ask, how are patients with this condition typically treated at UF? What is the standard of care? And is this going to be something that changes if somebody's in a study? So if you're doing something that's purely observational, you're not changing anybody's treatment, you're not randomizing them, all you're doing is watching them as they go through their medical procedures. You're not impacting standard of care at all. And that can be a very different type of study than something where maybe you're testing to see, is there a different standard of care that we should be using? Are there different treatments that work better? So when we ask people about standard of care in their protocols, essentially what we want to know is this a test that's going to happen anyway? Is it a procedure that's going to happen anyway? Or is it something that's only happening to people as part of the study? So the board does comprise, we are comprised of experts from a variety of different fields. But as you all know, when we get into sort of the details of treatment of individual conditions, you all are the experts. You're the ones who are doing this every day. So we may not know what is standard of care for a very specific population or a very specific condition, which is why we often ask people to clarify this in their protocols. Is this something that would happen anyway? Or is this something that you're only going to be doing because someone is part of the study? So it's important to clarify this, not just for each subject group, but also for each stage of the intervention. So if you have screening procedures that wouldn't normally be done, but you're going to do them to make sure someone's eligible, just add a note. Yes, this is something that we're doing as part of the research. Other common mistakes include inconsistencies between the protocol, informed consent, and SMART forms. So this can happen for a variety of different reasons. When it comes to the initial IRB submission, we all know that protocols can go through a variety of different iterations before they're ready to go. Things change, and especially as you're getting ready to submit, there's a lot of documents to get together. There's a lot of different details to sort of put into place and make sure that everything is ready for that submission. So sometimes edits happen to one document and maybe they don't happen to the other one. So we can see inconsistencies between the protocol and then these other areas. So specifically study staff and locations, we see it somewhat frequently there. Enrollment details, if you say you're going to be enrolling people from 18 to 75 in your protocol, and then you get to that SMART form and you say 18 to 80, we need to know, is it 75 or is it 80? So that'll be something that IRB staff, when you go through pre-review, will flag and ask you to make clear. And then the time required for subjects. So if somebody is going to be involved in your study, it may take 5 minutes to do a blood draw, but if you're following them for 3 months after their procedure, you're going to want to say people will be involved for 3 months, because you're still going to be getting that data on them. You're still going to be getting information. Maybe there's some sort of follow-up procedure, maybe there's not, but you want to make sure you mention, yeah, people are going to be involved for about 3 months. And this is also important to specify for each group. So again, in the case where you have students and parents in an educational intervention, you may have students who are involved for an entire semester in some sort of study, and you may have parents who are going to be, they're obviously around their students, but the only thing they really do is a 10-minute questionnaire at the end. You're going to want to mention, yeah, their kid's going to be in a study, so they're going to know about it. But the big thing they're doing is this questionnaire at the end. So it's just important to kind of tease this out. All right, recruitment. So how do we get participants? Recruitment is one of these things that can be challenging, but we have a lot of different tools for making sure that we can get participants involved in our research studies. So there's things like consent to share, research match, SONA, which is for recruiting undergrads at UF, various research contact registries, programs like Health Street. You also have the more, I don't want to say more typical, but when you think of recruitment, a lot of times we think of things like flyers and emails and phone calls, social media, and we have recently updated some of the social media policies. So if you're curious about that, you can also see the Brown Bag presentation that we had last month on social media recruitment, just as a little plug for that. And then recruiting patients who are either in the clinic, in the hospital, in sort of the actual stage of getting medical care. So there's a variety of different ways to get participants. A lot of times we also ask you to clarify the difference between people who are actively recruiting versus passively recruiting. So when we say actively recruiting, essentially what we're talking about is someone who's going to go up to people, going to hand them a flyer, going to talk to them about the study, going to give them different information, may take contact info, may give contact info out. And in a lot of cases, this might actually be the same person who does the informed consent. When we talk about passive recruitment, we're essentially talking about somebody who is only passing on contact info, maybe handing out a flyer, and that's it. So they're not giving details about the study. They're certainly not going to be consenting anybody. And really, they're just acting as a conduit for that information. And it's important to make these distinctions because there are restrictions on who can do specific recruitment type of activities. And if somebody is going to be involved in active recruitment, they need to be added to your IRB submission. So if you're recruiting in clinics and front desk staff, they're just going to be handing out flyers. And we're not going to ask that you put everybody on front desk staff on your study because, again, it's passive. All they're doing is really handing out info. But somebody who's going to be in the clinic asking questions, actively saying, hey, let's talk about this. We want to tell you about a study. That's going to be someone who we would want to have on the study staff in my IRB. So recruitment do's and don'ts. This is not an exhaustive list, but these are things that we do tend to see fairly frequently. So when it comes to what you should and shouldn't be doing, you want to make sure that everything you're going to be used in recruitment is given to the IRB, and you want to make sure that it's approved by the IRB prior to being used. So phone scripts, if you're going to be calling somebody off of a registry, just have a script. What are you going to say to them? Text messages, email templates, letters, flyers, if you're advertising in newspaper or radio, scripts for that, social media posts. And it's really important to present all of this, to turn it into the IRB in exactly the format that it's going to be seen. So especially with things like social media, sometimes you'll have longer messages for some platforms. So Facebook have a longer message and shorter messages for other ones. But we need to see, this is the platform and this is the message that's going to be presented to potential subjects on that particular platform. So it's really important to just make sure that if somebody is going to see it, we like to say anything that's subject facing, anything that subjects are going to see, turn that into us, just let us take a look at it. So again, it all needs to be approved. Things that are approved will be stamped. Don't make changes to approved materials without submitting a revision. This kind of goes along with the idea of only using things that are approved. This means any change, no matter how small it is. Often little changes can have very big impacts on studies. So don't make edits to your materials and then use them prior to that revision being submitted and approved. We also ask that you do specify who's going to be recruiting. Again, this is related to the notion that if somebody's going to be actively recruiting, we want to make sure that they're on the study. So it's important to say who's going to be recruiting, what subject populations they're going to be talking about, and where they're going to be going. If you're using listservs to recruit, you need to have a letter from the listserv manager saying, yes, this study is approved to recruit through us. We ask that you specify how you're going to be using each recruitment tool. So sometimes you'll see studies with multiple scripts, multiple flyers, multiple postcards, and without some explanation as to, okay, the flyers are going to go to people who are from our Health Street contact, and the scripts are going to be for our consent to share patients. Without that sort of specification, it can be difficult for IRB staff and reviewers to determine who is getting what. Sometimes the messages are almost identical, but sometimes they can vary. So it's important to just clarify that. So in the recruitment smart forms, just go through and mention, this is the flyer and this is who we're going to be sending it to. And kind of related, all the websites, social media platforms, everything you're going to use, specify what they're going to be, and then specify this is the message we're going to be putting on Facebook. This is the announcement that's going to be going on Research Match. Again, it just helps staff and reviewers sort through things and make sure that everything follows, make sure that all of your materials follow any requirements for specific platforms or populations. In terms of things that, again, you want to avoid, emphasizing the amount of compensation comes up fairly frequently. So if you have a flyer, it can't be, on the top research study, here's what you're going to do. Big bold letters, earn $50, and that's in red text, and there's a bunch of exclamation points. We don't want you to do that. It can be kind of coercive. We don't want the first thing people to see to be, earn this money. We want to make sure that they see it's a research study. There's other things that they're going to be asked to do. and then it's okay to talk about compensation. And again, you can say that people will be compensated, just don't emphasize that amount. We also say that it's UF policy that we don't engage in cold calling. So essentially what that is if you're recruiting subjects who have a specific medical condition, we ask that you can get your list of people who might be eligible. Providers can obviously recruit patients that they know would have that condition. But the people who actually do the recruiting need to be someone who has a clinical relationship with that person, who would have some reason to know about it. So a lot of the times what we'll see clinical staff talking to patients saying, there's a study, we think you might be eligible. Would you like to talk to somebody on the study team about this particular opportunity? And that's completely fine, because the first person to approach that patient is clinical staff, somebody who they already know and who has a reason to know their health information. And then you can have those people pass off the patients if they're interested to you. And then sort of the last one that we see sometimes come up is using non-UF email addresses in recruitment materials. So if it's going to be a UF study and you're going to be recruiting, you're going to be sending it through the UF IRB, you have to have a UF email address in the recruitment materials. No yahoo.com, no Gmail, nothing like that. It's got to be the UF one. Informed consent. So informed consent is arguably the most important thing that we do as researchers. When we're doing human subjects research, it's really, really important that we're transparent, that we're open, that we're honest with the people who are volunteering to share their time, share their tissue, share their information with us. So informed consent is an ongoing process. It's something that's really, really important. It lets subjects know about the research, what to expect if they sign up for the study, and then gives them info about risks, benefits, and other things that they may want to consider for participation. It's not just signing a piece of paper and then you can do whatever the study procedures are. When we talk about informed consent, we're talking about making sure that our subjects know specifically what's going on at every step of the game, that we're there to answer questions, and that they have that opportunity to continue participating in the study, knowing full well what's going on. So there's some elements of consent that are required. We do have a lot of templates. We have a lot of standardized text that's linked to later in this that will give you kind of a starting point for writing your consent documents. But I at least want to touch on some of the things that are required. So you have to have a description of the research study. It doesn't have to be exhaustive. It can just say, this is a study. We are looking at calcium levels in the blood of people with X, Y, or Z condition, or we're looking at the impacts of this reading curriculum on students. Risks and discomforts. So for minimal risk studies, probably won't be a ton of them. We do say, is there any sort of risk of a data breach? That might be something to mention there. In greater than minimal risk studies, especially things that end up, full board studies, things that could have bigger consequences, this section can be a lot bigger because it needs to tell people what these possible discomforts and problems might be. Benefits. So people who participate in studies, they don't have to benefit directly from it. So when we say direct benefit, we mean, are they going to have their health, their well-being, their lives improved directly as a result of being in this study? And there's a lot of studies that we approve where the individual subjects, they don't directly benefit. So if you are doing a social sciences study and you're studying messaging in political campaigns, the individual people who are going to be participating in that study, that's not necessarily something that's going to impact them in their daily lives. They might benefit in the long run because we're gathering information, we're gathering knowledge, but we wouldn't say that they directly benefit. And so that's okay. We just need to be clear whether or not people are going to benefit from being in the study. Alternatives to participation. So for biomedical studies, sometimes this is talking about other types of treatments, other things that people might be able to do, stick with standard of care. For other studies, social sciences studies especially, the alternative is just not to participate. If you're dealing with students, and you're doing something in the classroom where people might be earning extra credit, you would give them an alternative to participation too. So it would be a different way to earn extra credit other than participating in the study. Confidentiality. This is essentially how people's data is going to be collected, how it's going to be stored, who's going to have access to it. Most of our templates have fairly extensive confidentiality template language. So if you follow that, you should be in good shape. Compensation, this is another one. Medical treatment in the event of an injury. This is another one where we have a fairly extensive template language, but the individual compensation amount is obviously going to be specific to your study. And some studies don't have any compensation, and that's fine too. Contacts, so if somebody's interested, if somebody has a concern, if somebody's involved in the study and they need to get to you, they need some more information, who do they get in touch with? And then a statement of voluntary participation. This is really important. We want everybody to know that they don't have to be in the study if they don't want to. There's never any sense of, if I don't do this, something bad's going to happen. My doctor's going to be mad at me. My teacher's going to be mad at me. We want to make sure that everybody's participating freely of their own volition and that they know that. There's some additional elements of consent we'll kind of touch on briefly here. Unforeseeable risks. Are there things that might come along later that might impact subjects that maybe you don't know about right now? Some cases there are, in other cases there's not. Can subjects' participation be terminated if they don't show up to their appointments or they stop participating in the educational group? Can you say, you know, you're not a good fit for the study right now? Cost to participate. This is something where in the biomedical realm, you'll be working with one of our ancillary offices and they'll help get that language into shape. What happens if a subject withdraws? Do you keep the data that was collected on them up to that point? Do you discard it? Are there risks to people if they stop? So that would be primarily biomedical. If somebody is on a study drug, how do they stop safely? Is there any risk of them, you know, just stopping the drug? You would want to make sure they knew that. Are subjects going to be informed of new findings that might make them not want to participate anymore? And then the approximate number of subjects who are going to be involved. And this one, again, goes back to that kind of sneaky thing about your different subject populations. If you're looking at 20 students and their parents, you know, it's tempting to say, well, we're looking at 20 students. But if the parents are also subjects, you're actually looking at 40 people. Written informed consent. So it needs to describe, again, exactly what's going to happen to the subjects. Sometimes it is easier to have different separate informed consent documents if you have different populations undergoing different procedures or different enrollment criteria. So it can be difficult to write an informed consent document for example, people who have a medical condition versus controls. You might be doing a more extensive intervention on one group than on the other. So it can be difficult to sort of craft an informed consent that gets across the notion, this is what's going to happen if you are someone who has that condition versus if you're in the control group. So sometimes it's easier to actually have separate documents for these different populations. And especially if you're doing something like with providers and patients, where the only thing the provider is going to do is fill out a survey at the end. It can be a lot easier rather than presenting that to them in the context of all of these other procedures, all of these other treatments, just have a small consent for them. We ask that you write at an 8th grade level or thereabouts. We have a glossary of lay terms that helps translate some of these concepts into more understandable language. There's other things that you can do to make your informed consent more readable. And again, this goes back to when you're so involved in the research and you live it and you think about it in your sleep, it can be really easy to get so close that you forget. Somebody who's not involved in the research that in depth, they may not necessarily know what's going on. So that's why we ask you to sort of make sure that your informed consent documents are going to be understandable to somebody who's not that closely involved in the study and who may not have the same background as you. They may not have a medical background or an academic background. We ask that you include required template language. There's a whole page, it's linked to right here, with template language that you'll be including if you're doing various procedures, collecting various types of data. So if you're recruiting if you have a consent document and you're asking parents to sign for children, there'll be a box that says you or your child. It tells people, when you see you in this, we mean your child. Reproductive risks, certificates of confidentiality, that type of stuff. So we do have a lot of templates, which is useful, but it can be confusing which one to use. So the investigator guideline on which template is linked to at the top. But sort of in general, there are a couple of different types of consents. So full consent, that is the bigger one. It's got more questions. We usually use that one for greater than minimal risk studies, or for minimal risk studies that either are more complicated, they can't be explained in the short form. They just have more detail going into it than would be captured by a brief consent. The brief consent ones, we generally restrict that use to minimal risk studies. And the definition of minimal risk is where the intervention and involvement of the study subject is minimal and easy to explain. So that's kind of how we describe it for that particular consent. And you can figure out whether or not you can use the brief consent. One of the things that we see is people start off with the full one, and it doesn't actually, you don't actually need it. So if you start off with the full consent and you get to item 7 in the full consent, and you realize you're mostly including template language and you're repeating yourself, you already talked about study in item 5, that's a good indication that you can go with the brief consent, because that's saying, these shorter descriptions are sufficient to describe what's going to be happening with subjects. We also have tissue and banking consents if you're only banking tissue or data, and then contact registry consents if you're only trying to get contact info so that you can contact people for later studies. So in terms of the SMART forms, there's going to be a specific SMART form that details the consenting process. You're going to want to describe how each group is going to be consented. Again, think back to your separate subject populations, especially in a lot of different studies. It's tempting to focus solely on how you're going to recruit or how you're going to consent, the children in your study, how you're going to get assent from them, or how you're going to get consent from patients. But if you have these other groups, parents, teachers, doctors, it's important to talk about how you're going to get consent from them too. So is this going to happen in person? Is it going to happen online? When are they going to be doing this? Again, who is going to be doing the consenting? If somebody is going to be getting consent, they have to have that obtains informed consent role in my IRB. They have to be permitted to consent. So we do have some restrictions. So for greater than minimal risk studies, for example, undergrads are not permitted to consent subjects. So it's a good thing to just check that guideline that's linked to right there. Make sure that anybody who's going to be involved in consenting is eligible to do so. And then if there are any other restrictions on consenting, so if there's a conflict of interest, sometimes the conflict of interest office will say this person can be on the study but shouldn't be the one getting consent. We also have a question, and it's important to consider the issue of coercion. So this happens if you have perceived or actual authority of the person getting consent. So if somebody is approaching a potential subject and that person is an authority figure, like somebody's boss, somebody's doctor, or is just somebody who seems like they would have that sort of authority over the particular subject. So maybe they are a student teacher in the classroom and they don't actually have the powers of the teacher, but they might seem like they do if you're 13 or 14. And then there's other types of pressure. So if you're enrolling kids and parents, is it something where the parents might really want the kids to be involved in the study? So when we talk about coercion, it really is a matter of evaluating the different power dynamics involved in everybody who is going to be part of this consenting process, and seeing are there things that we might be able to do to minimize this. So if it's something with parents and kids, are you talking to them together? Are you asking them to consent at the same time, at the very same place? There's a variety of different things you can do to minimize coercion. And then letting subjects ask questions. So whenever you talk about consent, you have to have a place for questions, a process for getting questions answered, and then time for subjects to ask them. So we're going to talk briefly about eConsent and remote consent. So when we talk about eConsent, we're talking about consenting subjects online. A lot of times this is with something like red cap eConsent. Remote consent is not the same thing as eConsent. When we talk about remote consent, essentially we're saying that the person doing consent and getting the consent and the person giving consent, the participant, they're not in the same place. So remote consent can be you mail a consent document to somebody and you go over it while you're on the phone, and then they sign it while they're at their kitchen table and you're on the phone with them. So remote consent can involve eConsent, but it doesn't have to. So again, whenever we're using each of these, we want to make sure that it's really clear who's going to be doing the consenting, how are the consents going to be reviewed, how are subjects going to have a chance to ask questions. And then I've linked to investigator guidelines here at the bottom. So the last thing we're kind of going to talk about is study documents. So this is, I saved this for last because it applies very broadly to everything we've talked about today. So protocols, consent documents, recruitment materials, all of these things get uploaded to my IRB. We ask that you use Word format, and this is for editing. So if you use PDFs, you can't edit PDFs. If you use the Word document, you can edit that and you can use track changes. So we require that if you're going to make changes to a document, you do use that track changes. We try and keep track of all the studies. We see several thousand every year. We see more revisions even than that. So it really helps my IRB staff, the IRB staff and the reviewers to have that track changes on so we can see specifically what's been changed. This saves us a lot of time, which makes reviews go a lot more quickly. And it also means that there's fewer times where we have to get back to you and ask questions. So we ask that you use track changes when you're making updates. However, we ask that you accept prior changes before making new edits. So essentially the document that you upload should have only things that were changed in this specific update of that document. So accept all of the other ones, make your changes, then upload it. And also remove staff comments. So sometimes as documents get passed back and forth between people, you'll have people asking questions in the comments or seeking clarification. You want to make sure that you address all of those questions and then you remove those comments prior to submitting. We also ask that you never edit stamped documents. So this is going to be your informed consent forms and your recruitment forms. So the stamp that comes at the top of the document with the IRB seal, that's how we know that we've seen the document and that it's been approved. So if you edit those documents, we end up with things that we've not approved that already have that final step stamp. So never edit stamped documents. Instead, we ask that you go into the study workspace, you find the appropriate smart form, so your protocol, recruitment, what have you. Download the most recently submitted version from my IRB and then edit that and you can upload it. So that's a really easy way of making sure that you're not editing something that's been stamped, that you're editing the most recent version of that particular document. All right, so we're gonna go to questions. So what questions do we have?
Hi, Lauren, this is CJ.
Hi.
Thank you for today's talk. Is really helpful for me to understand more about the consent and documentation. So I have a question about the consent. Can you do that in stages? Because you know the procedure, if like you say it's too complex, or you're going to randomize people and one group are going to go to the usual care. So, you know, can you have a stage first, maybe just consent for the baseline and randomization, and briefly describe after randomization what will happen, and after you randomize people, then the control group have another consent and the treatment group have another consent.
Yeah, so this can be a little bit tricky. And this might actually be something where, depending on the specifics of the study, it ends up being a reviewer's call as to whether or not that is something that ends up permitted. We do have some studies that do what we call a screening consent. So if somebody has to do an MRI and 6 questionnaires before they can be enrolled in the study, you can have it where people consent to being screened and then do the consent for the full study. I haven't seen any that do consenting in stages in terms of the randomization. That might be something that, depending on the specifics, the reviewer would need to weigh in on. So the answer is kind of. but it's going to be very context specific. I'm sorry I can't be more detailed.
That's okay. I think it's possible, but just you probably the IRB have to think if it makes sense within that study design and purpose.
Yeah, and it depends on sort of what's happening at what stage. So that
Sure.
that's something that we, and if you have specific questions, reach out and we can obviously talk and kind of think through that individual situation.
Okay. And my second question, I don't know if it's related to today's topic, is about minimal risk. I sometimes have a hard time to, even myself to quantify is a minimal risk or is more than minimal risk. So can you give me more guidance about this?
Yeah, so when we think about minimal risk, essentially what we're thinking about is, are the risks associated with the study going to be something that people would experience in everyday life? So filling out questionnaires, generally speaking, those are considered minimal risk. People give information all the time, especially if it's not particularly sensitive. Ultimately, the distinction between minimal risk and greater than minimal risk comes down to the board. So if it's an area where, so if it's an expedited study and there's kind of a question as to whether or not it's minimal risk or greater than minimal risk, the full board will take a look at it, and they're actually the ones who make that distinction. But that phrase, is this going to be comparable to the risks that people see in everyday life? That's kind of the goalpost for it.
Okay, so is it possible when you don't think is more than minimal risk about the review or something, the screen staff, you see this, you think it can be more than minimal risk, it will bump up to the full board review?
Yeah, so things that are greater than minimal risk always go to the full board.
Okay, so not only the investigator do the judgment, but the pre-screener staff will also do the judgment.
Oh, no. So the pre-review, we don't make that judgment. The reviewers always make that judgment. So we take a look at it, and then if you're submitting something expedited, we send that to one of our executive reviewers. They would be the one to say, this might be greater than minimal risk, and they're the ones who'd send it and have the full board weigh in on it.
Okay, thank you. I know that, sometimes minimal risk, it's sometimes not black and white. I mean, a very simple procedure can increase the risk depending on the population.
Yeah, there's a lot of things that go into it. But yeah, that's why if there's question, we always defer to the full board.
Okay, and I have one more last question. Who do the consent? I know that you already described, the figure people who've been perceived who are coercion, should not provide the consent, for example, their healthcare provider. But now there's increasing the people doing implementation studies, and it's more similar to the practice real world. Like, for example, when we go to the doctor, is your doctor consent you to do the medical procedure. So in this type of study, I just would like to know the IRB, how to respond those kind of, it would be maybe more this kind of study happening.
Yeah, well, so just to clarify, we're not saying that doctors can't consent their patients to be in studies. The question specifically on the SMART form just asks whether or not there's a possibility of coercion. And if there is the possibility of coercion, what steps can be taken to minimize it? So yeah, I mean, obviously there's a lot of studies where providers end up consenting their own patients. And actually they have that clinical relationship. So they have that information already. They're allowed to recruit and they're allowed to consent. It really is just a matter of emphasizing the voluntariness of the study, making sure that people have a chance to read the documents. And then if there's any other specific practices in place to make sure that people don't feel coerced, that's the kind of stuff that we would ask you to detail in the SMART forms.
Okay, thank you.
Do we have any other questions? All right, so I'm not, check the chat here. All right, so I'm not seeing any other questions. Well, thank you all so much for coming. This will be posted on our website. We'll link to it in our newsletter. And as always, if you have any questions, if there's anything that wasn't clear, anything you want to discuss, reach out to me, reach out to the other IRB staffers. We're always happy to help. Thank you so much. And I hope you all have a really great rest of your day.